Should we go ahead and get started?
Sounds great.
All right. Well, good morning, everyone. I just want to, it's my distinct pleasure this morning to introduce our speaker, Dr. Mark Shrime, as our grand round speaker this morning. Dr. Shrime is a microvascular head and neck surgeon who trained at New York Presbyterian and University of Toronto. He obtained his MPH and PhD from the Harvard School of Public Health. But he is a man of many hats and is incredibly accomplished. He's an internationally recognized expert in decision-making and surgical care delivery in low and middle income countries. He's a book author. He's a TEDx speaker, and he currently serves as editor-in-chief of BMJ Global Health and as a lecturer in global health and social medicine at Harvard Medical School. He's authored over 200 papers on global burden of surgical disease, the financial burden of facing surgical patients, and the number of people who can't access safe surgery worldwide. And he's held a number of roles. I'll briefly run through some of them. Director of the Center for Global Surgery Evaluation at Mass Eye, Research Director for the Program in Global Surgery and Social Change at Harvard, the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland, and he's also served as Chief Medical Officer of Mercy Ships, for which he has worked as a surgeon since 2008. So today, Dr. Shrime will be sharing his experience with Mercy Ships and the global surgery crisis. Thank you so much, Dr. Shrime, for being with us today. We're so fortunate to have you and look forward to hearing your talk. Thank you so much.
Thanks, Michael. The many hats is basically because I have no hair left, so I got to do something to, cover the head.
Nice.
Let me see if I can share my screen. All right, Michael, you're still on my screen. Can you confirm you can see it?
That looks great.
Perfect. Great. All right. Well, thank you all for being here. Thanks for the opportunity to speak with you all today. As Michael said, my name is Mark. I'm going to be speaking today about the role of NGOs in global surgery. I'll be doing that primarily through the lens of my work with Mercy Ships, which I'll kind of introduce what Mercy Ships is about halfway through the talk. But I do want to talk a little bit broadly about the role of the NGO, the non-governmental, the charity, philanthropic sector in global surgery. A caveat here, disclosure here. So I have been, and when I actually agreed to this talk, was the Chief Medical Officer for Mercy Ships. I've since moved on in December of last year to be the editor-in-chief of BMJ Global Health. So I'm giving this talk not as a representative of Mercy Ships. I'm giving this talk from my own experience, 17 years, since 2008, 17 years of volunteering with them and 3 years as their Chief Medical Officer. My successor came into his post at the beginning of January, so it's been 6 weeks. He's still getting his feet under the table, and I'm sure he will have his own directions for the organization. So just that disclaimer to say. All right. So I have two disclosures. They aren't necessarily relevant. I get some consulting and some scientific and academic consulting funding through Global Surgery Advisors. Spend a lot of my time these days with healthcare providers, healthcare professionals who are burnt out and not feeling like they want to do the same thing for the next 20 years of their lives, using decision science to sort of craft a path towards what does the second half of a medical career look like. I am happy in the Q&A session to talk about global surgery, to talk about Mercy Ships. I'm also happy to talk about academic publishing from the BMJ side or any of the things that are on this slide. But today's talk is going to focus on this. So I'm going to talk about what is global surgery. What do we mean by global surgery? Seeing the names on the screen, I know some of you, at least in this room, are very aware of what global surgery is. I'm going to take a slightly different approach to this question. I'll give you some of the numbers, but I want to take a bit of a different approach. And then I'll talk about who Mercy Ships is and how Mercy Ships responds to the global surgery crisis through direct service provision, through education and training, and through advocacy. This talk is usually about 30 minutes long, so hopefully there'll be plenty of time at the end for questions across any of the things that I talked about. All right, but before I even do that, it is difficult to exist in the global health space, global surgery space. It's difficult to talk about it. It's difficult to write about it. To be an editor of a journal in global health over the course of the last 5-6 weeks, with everything that has happened in the global health space, everything that's come out of Washington, D.C. Since the end of January has led to, I mean, I'm using the word destruction of global health here through the rise of hypernationalism. And I don't know that that's necessarily an overstatement. A fair number of organizations in the global health space have used words like this is an extinction level event. as well as patients who are feeling the effects of the US's withdrawal from the global health space, both through its withdrawal from the WHO and its dismantling of USAID. Patients who are reliant on funding for HIV medications are no longer getting it. And, patients like quite literally are having their oxygen turned off because the funding for it is no longer there. So what's happening right now in global health is it's really hard to know what's going to come on the backside of it, where things are going to settle out. But this is a significant moment in global health, not necessarily a positive significant moment due to this rise of isolationism and nationalism, which is a rise historically, right, that we saw in the 1840s and that we saw in the 1930s, and we're seeing again in the 2020s. But I want to talk about this in a little bit of a less polemic way and a little bit more of a drier, potentially, approach to this. And that's to talk about what this does to funding for healthcare systems. Broadly, healthcare systems around the world are funded in one of four ways. They are funded through the multilaterals. By that, I mean the WHO, I mean the UN, the World Bank, each of which has various size pots for funding for global health. So those big multilateral, multi-country initiatives like the WHO. A lot of funding for these systems also comes from the bilateral agreements. So the US and Rwanda, the UK and Sierra Leone. So USAID has a lot of bilateral agreements between bilateral two countries getting into an agreement. There is a lot of funding and a lot of on-the-ground work that happens from the sector that we're talking about today, which is philanthropy and the non-governmental organization sector, the charity sector. Now, fundamentally, healthcare systems should be funded locally, right? It's the way our healthcare system is funded. Healthcare systems in much of the global north are funded in a way that the funds are raised from the population itself and then funneled into the healthcare system. Now, in many countries, that raising of funds from the population is through taxation. In the US, we do that a little bit less. We just raise funds by charging the heck out of our patients. Either way, fundamentally, that funding is local. So we aren't, as a healthcare system in the US, reliant on big donations from Liberia to fund our healthcare system. In many countries in the global south, the taxation systems and the health systems are not necessarily in place for that local funding to happen, due to a variety of reasons, not least of which is a legacy of colonialism. But that, although the healthcare systems should be funded that way, that the reality on the ground is that that does not necessarily happen, and healthcare systems in the global south tend to be more reliant on the other three layers of this funding. And as we've seen in the last 5-6 weeks, these layers of funding are at significant risk. So the withdrawal from the WHO from the US, and I forget the numbers, but I think the US is 1/3 of the WHO's budget, significantly puts funding for multilaterals at risk. The dismantling of USAID significantly puts funding from the bilateral sector at risk. Local funding, not so much at risk if it existed, but it's not well structured. And that leaves healthcare systems in the global south reliant on two broad buckets of funding. There are innovative financing mechanisms, things like social impact bonds. Super cool, super interesting, kind of potentially a really good way of doing this, but not really tested at scale. And that leaves philanthropy. Now, I want to say right now, even though we're going to spend the rest of this talk talking about the NGO sector, this is not the right answer. This is not the right answer for how healthcare should be delivered or funded at the country level, because the NGO sector, the charitable sector, the philanthropic sector is itself very donor driven. It's got very individual interests at play, which means that to varying degrees, NGOs do or don't partner as much with the healthcare system that hosts them, sometimes not at all. And sometimes, again, philanthropy and the NGO sector is neocolonialism wrapped in money and a smile. I don't think this is the right answer. This is not the right answer for the health system financing side of things and for the building of sustainable health systems at the local level. However, it is the reality that it is a sector of financing that is at less risk given everything that's been happening in the world today and this rise of isolationism. So with all of that background, then let me move to That's global health funding as a whole. Let me narrow down here to global surgery and the role of mercy ships. And let me ask the question, what is global surgery? Now, as I said at the beginning, I think a fair number of you probably know a lot of the papers that are out there. The Global Surgery Initiative at UCSF is pretty huge. So you'll know that 70% of the world's population doesn't have access to surgery, or you will probably have heard that people get impoverished. Half the world is at risk of poverty if they need surgery today, or 6% of the world's 6% of the world's surgical procedures are performed in low-income countries where something like 33% of the world's population lives. You know all that. I want to take a little bit of a different approach to defining what global surgery is, and I want to do it through the lens of a patient. This is Dauda. Dauda is a patient that I met when I was in Senegal with Mercy Ships in 2021. You can see one of our hospital ships docked in the background on that left-hand picture. Dauda's father has given permission for these pictures to be used. Dauda was 13 at the time, and he'd had this tumor growing off of the right midface for the last 6 to 8 years. The story varied a little bit depending on who you asked, but the last 6 to 8 years, he'd had this tumor growing off of his right maxilla. Now, the maxillectomy, the procedure that we do to take this tumor out, is one of my favorite procedures to do. I absolutely love maxillectomies. They are fascinating geometry and anatomy to take the mass out, and also super fascinating to reconstruct, especially in resource-constrained settings where free flaps are not readily available. How you reconstruct the maxilla is a super fascinating geometry problem. But I actually don't want to talk about the maxillectomy itself today. I want to talk about his procedure. I want to talk about what happened before he got his procedure. On Mercy Ships, we admit all of our patients the night before surgery. So with the exception of cataract patients, everybody is admitted the night before surgery, which gives us an opportunity, if we have the time, to sit down with the patients the night before and ask for their story. And I did. I asked Dauda's father what happened in the last 6 to 8 years. Right? Because it's not as if he woke up the day before and was like, oh my God, look at this big tumor on my son's face. The family knew, right, that tumor was there and that tumor was growing over the last 6 to 8 years. I wanted to hear the story of what happened in that time. And like any other father, when Dauda's father noticed the swelling on his son's face, he did what any other parent would do and started to try to find care for his son. Now, they live on the eastern border of Senegal. There's a schematic of Senegal right there in the upper right-hand corner, with the Gambia being the little finger of white that goes into the middle. So they live on that eastern border where Senegal borders Mali. So he started going to the clinics, the health posts that were around him, and no clinic or health post there was able to do surgery for his son. So he then took his son on the 100-kilometer road from where he lived to the nearest big city, a city called Tambacounda. And Tambacounda has a referral hospital in it. So he took his son from that border with Mali over to Tambacounda, stopped at the health post along the way, went to the hospital there, and in no place could he find all of the things that are needed, the ORs, the surgeons, the medications, the equipment, the systems that are necessary for Dauda to get his surgery. He then took his son down that 500-kilometer, that 300-mile road between Tambacounda and Dakar, the capital of Senegal, multiple times, back and forth across those 6 to 8 years. He said to me, he said, nobody on that road from Tambacounda to Dakar does not know my son. He stopped at every health post, every clinic, every place he could. He says he went to every hospital in the capital, in Dakar also, and couldn't find the people, the ORs, the medications, the systems necessary for the surgery to be done in a way that also wouldn't put them at risk, or would not impoverish them, would not bankrupt them. Over the course, speaking of that, of those 6 to 8 years, he spent 6 million CFA, 6 million francs to try to get, and not actually successfully get, care for his son. Now, if you go to xe.com and you type in how much is 6 million CFA in US dollars, it's approximately 10,000 US dollars, which is already a pretty big sum. Like, I would very much like not to be faced with a bill of $10,000 today. That is a big sum already, but it does not tell the entire story. At the average Senegalese salary, I have no idea how much money Dowda's father makes. I didn't ask him. I suspect it's not the average Senegalese salary because he lives far, far out from any of the big cities. But at the average Senegalese salary, it would take 69 months to amass 6 million CFA. And that is if you put every single penny of that into amassing that amount of money. That means there's nothing left over for food. There's nothing left over for school fees. And it's and specifically that actually happened. The rest of the kids and Dowda could no longer go to school because all of the money was going to try to get care for their son. 69 months of salary, of the average American salary for a family of four, is $335,000. Now, that is a crap ton of money. That's the technical term. A crap ton of money to just try to get care unsuccessfully for your son over the 6 to 8 years that he'd had that tumor. So if we look at global surgery through the lens of Dowda's surgery, Dowda's tumor, we see all of the various things that need to align for Dowda to get care. We see all of the different barriers that Dowda and his family have to overcome to try to get that tumor out. We see barriers on the demand side, on the patient side. So cost, distance, transportation, very often, not in Dowda's case, but very often there's also simply the health literacy is such that there's a lack of awareness that surgery is a treatment option for the thing that you have. And then when you've got that awareness, and even if you try, if you have the means and the transportation, et cetera, you face barriers on the supply side of a lack of surgically trained providers, a lack of surgical infrastructure, supply chains, quality, safety, et cetera. That is global surgery. That is what the global surgery movement is trying to fix. And the reason is, if there is movement in this, we get a whole bunch of outcomes. We get outcomes on the demand side, on the patient side, including the health outcomes, which as surgeons are the first things that we think about. Like, did the tumor come out? And I will show you a post-op picture of Dowda at the end. Did the tumor come out? Did he have complications, SSIs, et cetera? But then there's the next level of outcomes, the non-medical outcomes of medical interventions. Like, was Dowda's father able to return to work? Was Dowda able to return to school? Did they, in his case, yes, did they face financial catastrophe? Was there shame and social isolation before the surgery? And did that persist after the surgery? Improving the right-hand side leads to an increase in the number of surgeries, simply just the number of surgeries provided in a country, let alone the number of providers, hospitals that are capable of providing surgery. I will talk about this again in a second, but surgery is annoyingly horizontal, and that resists the philanthropic and charitable sector, because in the philanthropic and charitable sector, we like to be pretty vertical. We like to be like, all right, we're going to come in and we're going to fix the supply chain. All well and good, we need a fixed supply chain, but what's the point of a fixed supply chain if there are no providers who can dispense the drugs that you now supply? What is the benefit of training the providers to dispense it if you don't have the anesthesia machines to do the dispensing, and so on and so forth? You don't have the ORs to do it. Surgery is annoyingly horizontal in that you have to kind of fix all of it for all of it to get better because it's so intertwined, which makes it hard. But it also gives it significant positive externalities. If you fix the electrical system and the oxygen and the vac and the suction for surgery in a hospital, well, you have fixed the electrical system and the oxygen and the suction for the hospital as a whole. So in theory, at least, there is significant positive externalities, significant knock-on effects for focusing on surgery because of how horizontal it is. Okay, so that's what we're talking about here when we talk about what global surgery is. Let me now move to Mercy Ships, which is one of the charitable organizations that's working in this space, trying to improve across that annoying horizontality. Mercy Ships, real briefly, is an NGO. It is a non-governmental organization. It's a charity. It comes out of and still has roots in the religious sector, primarily focuses on the global surgery crisis. As you can tell from its name and from that picture that I showed you before, we do all that from the decks of hospital ships. So over the course of the nearly 50 years that the organization's been around, since 1978, We've had 6 hospital ships. There are currently 2 that are in active service and another one that's being built right now. One of our hospital ships just pulled up into Madagascar, where she will spend almost a year after having already spent a year there. And the other hospital ship is midway through a 3-year stint in Sierra Leone. We bring the ships into a country for about 10 months at a time, and then we leave for dry dock for refurbishments and repairs and restocking, et cetera, for about 2 months at a time. Then we either come back to the country that we're in or we move on to the next country. We tend to stay in countries for 1 to 2 years at a time. Occasionally, as in the case with Sierra Leone, we'll stay an extra year, a 3rd year at the invitation of the Ministry of Health. That's the platform that we use to provide all of this care. To break down the care that we do, I want to turn to this quote, which is probably not by Desmond Tutu. It's one of those apocryphal quotes that like showed up on the internet one day and got attributed to Desmond Tutu. If you try to dig into this quote and try to find out who actually said it, it's really difficult. I've tried. I can't figure out who said it. So I'm just going to say it's Tutu. Probably not. But anyway, the quote is, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in the first place. And what I like about this quote is the word that I've italicized, is the word just. If you have existed, read about, been in the global health space for any amount of time, you've started to realize that there's a pretty significant cleft, a pretty significant division in the global health space between relief and development. What I mean by that is relief is Dowda has a tumor, it needs to come out. Development is Dowda has a tumor and you just spent 10 minutes telling me why that tumor got so big and why he couldn't get care. We need to fix all of that stuff as well. And there is a pretty big cleft. Everybody will say, yes, both are important, but to a large degree, people end up in one of these 2 camps. The relief camp will say, look, if you spend all your time fixing the road systems, hundreds of patients are going to die of their tumors like Dowda's, and they're right. But then the development side folks will say, look, if all you're doing is taking the tumor out of Dowda, then that line of people needing your care is never going to get shorter. And they're right as well. What I do like about how Mercy Ships has evolved over the last 5 decades is that we've focused on that just. We basically say, look, we need to do both. Dowda does need his tumor out. And also we need to work on that annoyingly horizontal surgical system. So we need to pull people out of the river and also go upstream and find out why they're falling in the first place. Let me talk about the pulling people out of the river. That is our direct medical services. That is the cutting and the sewing. It aims to treat the current surgical disease burden. And our goal in doing that is we want to decrease the current surgical disease burden in the countries that host us by fundamentally returning health to surgical patients, decreasing their disability due to their disease. We literally measure disability adjusted life years for all of our patients that are coming in. We follow them out for 12 months and have a fairly good, like an 85% follow-up rate for those entire 12 months. We aim to reach the hardest to reach patients. So because these are very big ships, we end up docking in either the capital or the economic capital of the country where healthcare access is the best. Dowda doesn't live in the capital of Senegal. He lives in a much poorer region of Senegal. And so we have a very concerted effort to get patients from outside of cities in which we've docked. We're super cognizant of the financial burden that getting surgery places on families. Everything that happens on Mercy Ships is free. The surgery, the medications, the food, the lodging, even the transportation to follow-up appointments, et cetera. All of that is free. However, even with all of that, there's still a financial burden of having to be in Dakar for 2 months as you go through all the post-op visits and not be with your business, with your store, with your farm, whatever it is that produces money for you. We're also really cognizant of the fact that sailing in these big white hospital ships, we don't go under the radar. It's hard not to notice these things, and probably this has an effect on the market for surgeons in these cities. We know that qualitatively, we know that anecdotally. We're embarking on a study to actually quantify that on the ophthalmology side of things. Fundamentally, our goal is this last line, which is to restore to patients and families their right to a seat at the table of humanity. And what I mean by that is if you've had a tumor on your jaw like this lady here, or on your maxilla like Dowda for 8, 10 years, something changes in the way people interact with you. People no longer look you in the eye, they look you in the tumor. You become that tumor. There's a quote from Napoleon that says, "The man becomes the man of his uniform." And if your uniform is a big tumor growing off the side of your face, something changes in you. You start to perceive, and others start to perceive, that you no longer have a right to sit at the same table of humanity that the rest of us sit at. So fundamentally, our goal, and we've worked on ways of measuring this, is to restore to patients and their families that right to having a seat at the table of humanity. We do that through basically the cutting and the sewing. We have 7 surgical specialties that we do. So we're a specialized surgery center to a large degree across these 7 specialties. So head and neck maxillofacial surgery. We do reconstructive plastic surgery. We do general surgery, including goiters. We do specialized pediatric general surgery, pediatric orthopedics, primarily the bowed legs. Depending on the country, we sometimes have a clubfoot casting program. We do ophthalmic surgery, primarily in the form of cataracts, and women's health surgery, primarily in the form of obstetric fistula repair. We also have a very large dental service, and then we have a smaller palliative care service for patients who come with tumors that are unresectable, that are likely to be terminal. While the ships are in countries for the 1, 2, 3 years, we have a palliative care team that visits those patients, provides counseling, provides medications, pain medications, etc. Now, I say all this as the tip of the spear. A lot of what I was talking to you about with Dowda's case is that it's, the annoying horizontality of surgery. None of that cutting and sewing happens in isolation. And the reason that we can do complex head and neck surgery, the reason that we can do complex reconstructive surgeries, is because the surgery, the anesthesia, is supported by a massive team, a team that we have in our own hospitals at home, but don't necessarily exist in the hospitals in the countries that host us. So nursing, lab, radiology, rehab, biomed tech, sterilization, speech therapy, nutrition, pharmacy, hospital chaplaincy, I mean, you name it. We are able to do the complex surgeries that aren't necessarily being able to be done in the local hospitals, not because our surgeons are better, not because our nurses are better, but because we have all of that infrastructure. We have reliable oxygen, we have reliable electricity, we have reliable water and suction, a reliable lab, a blood bank, etc., to allow us, to free us as the surgeons to do all those crazy things, like take somebody's face apart and put it back together again. That's the direct medical services. That's the pulling people out of the river. I want to turn to the second half, which is going upstream and finding out and hoping to try to fix why people are falling into the river in the first place. That is through our education, training, and advocacy, which we call ETA. So our DMS, or direct medical services branch, aims to reduce current surgical disease burden. ETA aims to reduce future surgical disease burden. In that annoying horizontality, our major focus, but not exclusive, which I'll show you on the next slide, is on the workforce. Our fundamental goal, or the metric that we try to measure, the metric we try to move, is the number of surgical providers available to patients. And by that, I don't necessarily just mean surgeons or anesthesiologists. I mean that entire ecosystem that I showed you a couple of slides ago. I'll give you an example of what I mean by that on the next slide, in the work we're doing in Sierra Leone. We create our educational programs in conjunction with the Ministry of Health. Again, I'll give you an example in Sierra Leone, but the goal here is that we're in country for 3 years, for example, in Sierra Leone. That education system, that education program needs to survive after we're gone. So we co-create it with basically aligning what we're doing with the goals of the Ministry of Health. We work to make it financially sustainable. We work to get it accredited in the country itself, as well as through international bodies. Again, just like we do with our direct medical services, we want to reach the hardest to reach providers as well. And then I'll have one slide towards the end on the advocacy work that we do, advocating for surgery's place in the healthcare system at national and international forums. The way we do this is threefold, 3 pillars, 3 pathways in education, training, and advocacy. We have programs on ship. That is primarily residency and fellowship training. So we bring on residents in surgery and anesthesia and occasionally in nursing for rotations on the ship. We have just, as of last year, gotten those rotations accredited by the West African College of Surgeons, and we're working now on accreditation from the relevant college also in East, Central, and Southern Africa. We also have a partnership with a big cross-continent residency training program called PACS, the Pan-African Academy of Christian Surgeons. Their surgeons spend 6 to 12 weeks training with us in particular specialties that their training programs don't necessarily have access to, specifically head and neck and plastics. Our goal is actual accredited one-year fellowships, right? Our ships are in country for a minimum of a year. My fellowship in head and neck was a year. The goal then is to be able to have accredited fellowships in pediatric surgery, in head and neck, et cetera, on the ships themselves. That's one pathway. If that's all we focused on, and we trained these folks in this like super fancy ship that has all the support systems that I just talked about, and then sent them back to hospitals where that support system doesn't exist, we set them up for frustration. Now, in 1 to 2 years, we're not going to be able to set up an entire support system in a country, but we do work to improve the system in the program, system in the hospitals that these program trainees go back to. We do that through biomedical. We do that through hospital leadership team. In Sierra Leone, we have a project that was at the request of Connaught Hospital, which is their big referral center in the capital, to decrease their SSI rate and to do that in a multidisciplinary fashion. So we brought along a bunch of partners to measure and do nurse training, infrastructure development, et cetera, to decrease the SSI rate. I told you that our primary goal is to increase the number of surgical providers in a country, and none of these two do that. These upskill the providers and improve the hospitals. That's where our third pathway comes in, which is partnerships with universities. And all of these are going to talk to each other. All of these are going to inform each other. Here, I want to give you just one example. Our biggest partnership is actually in dental in the country of Guinea. But I actually want to talk to you about Sierra Leone, because as we were preparing to come into the country, the Minister of Health asked us to focus on nurse anesthesia. Sierra Leone is a country of 8 million people, so about as many people as live in New York City, where I'm sitting right now, but there are only 2 fully trained anesthesiologists for those 8 million people in the country. And there were about 50 nurse anesthetists to cover the entire country. So in partnership with the Ministry of Health and the University of Sierra Leone, we've created a diploma program with path towards a bachelor degree in nurse anesthesia. Our first cohort is coming towards the end of their diploma program. The plan is 2 cohorts of 20 people each over the 3 years that we're in Sierra Leone, which will take the number of nurse anesthetists in the country from 50 to 90, as well as to create a career path for them. That doubling of the nurse anesthetic layer, nurse anesthetic, that mid-level cadre, is it going to fix the entire healthcare system? Absolutely not. But is it a dent in this? I'd say it might very well be. Last thing I'm going to say before I close is advocacy. Advocacy is hugely important. In many countries, there's still, and at the international level, even more so, there is still this feeling that surgery is the icing on the cake, right? We've got to figure out nutrition and maternal health and all this sort of stuff. And then once we've got it all figured out, then maybe we can turn to surgery. But listen, you and I would not agree to live in a country that didn't have a functioning surgical system. So a lot of what we also do is advocacy on the international level through the usual channels, the multilaterals, partnerships with other NGOs, but also through research output, also through the lay press. We also do advocacy at the national level and work to train our trainees in advocacy in their own countries, and then also leadership training to improve clinical governance, supply chain, et cetera, at the facility level. So advocating across international, national, and subnational levels. I'm going to close with a quote that is attributed to the person that I put here, which is a quote from Rachel Held Evans. Held Evans was a theologian. She died in her 30s. She died very young. She was a theologian. So this sentence is directed towards the church, but I actually think it's a really good sentence for any of us who are interested in the global health space. She says there is a difference between curing and healing. The difference between the cutting and the sewing and the actual healing of the patient and the actual healing of the healthcare system. And she says, I believe the church and I believe the global health community is called to do the slow and difficult work of healing. With that, let me end and ask if there are any questions.
Dr. Sharm, thank you so much for such a powerful and beautiful talk. Really wonderful. I've already been getting some messages from people that have been talking about how wonderful your work is, and many of us have encountered you and know you from different paths of our lives. So thank you so much for being here. I'd love to open it up for questions. If anybody wouldn't mind raising their hand, and I can call on you, or throwing a question in the chat. I would love to kick us off and get us started. Actually, my best friend from high school has worked at USAID for 10 years, and he learned a couple weeks ago that he lost his job, and it's always different when things like this are personal. Um, but sometimes, as residents, we're just totally in the depths of the hospital, and don't have our head up. And I always kind of curious, from your perspective, what do you think are the and your kind of use of research as a powerful tool for advocacy? What are the are you guys doing anything to quantify or project the impact of this curtailing of funding to the WHO and USAID? And then what do you think are the most effective ways, means of advocacy for the US to kind of try and restart this funding? What have you seen in the past based on your work? You kind of worked through any different avenues to do this?
Yeah, two really great questions. First of all, I'm really sorry to hear that about your friend. It's a sadly common story in the last 6 weeks. I'm really sorry to hear that. You ask a really interesting question, and putting my sort of editor hat on, we get a lot of submissions of, and name the crisis. This is true of Gaza as well. This is true of the USAID and WHO withdrawals and dismantling. This is true of sort of major crises that happen. We do get a lot of advocacy pieces, editorial style op-ed pieces, super, like 100% important. I'm not at all downgrading those. The research is unfortunately slow. Right? Like, we are still learning the effects of the pandemic. And that was declared 5 years ago, right? And so we're not going to know the research level effects on what's happening in Gaza for another few years. We know what the reports are. We know what the reporters have said, what the NGOs in that space have said, but the research, that's going to take some time. It's going to be the same here. It's what's going to end up happening on the research side is 2 years from now, somebody's going to do what's called a regression discontinuity and be like, okay, there was a major event that happened. Now we'll look at the mortality rates or whatever on either side of that event and see what happened. That's going to take a couple of years to do. What does that mean for us as providers, as residents, as professionals? I'm going to say a couple of things, and I don't want your administration to get mad at me. As clinicians, it's our duty to prefer that people stay alive. Fundamentally, we prefer people alive rather than dead. And I think we can't lose that. We are the ones that treat the patients who are impacted by these things. It's really easy to, when it becomes a question of, slashing budgets or whatever, it's really easy to depersonalize, to decouple that slashing of the budget from the effect that it's going to have on the person in front of you. And that's where we have our biggest impact, is on the person in front of us primarily. I'm a big believer in storytelling as a means of communication. I mean, I did it with Dowda's story here. I'm a big believer in that. And I think those stories, we need to be telling those stories publicly. We need to be talking about this publicly. Hey, this patient couldn't get X because of, the slashing in funding. That's what I would say. I mean, fundamentally, as residents, I think your biggest goal is to be the best dang resident that you can be. Also, to talk about these stories and how this high-level policy stuff is actually trickling down to the patient that's in front of you.
Thank you so much. Let's see, any questions here? Otherwise, I think maybe Dr. Zhu, Mary has a quick question. Go ahead, Mary. Thank you so much.
Yeah. Hey, Dr. Shrime, thank you so much for coming. Great talk, and always love learning from you, and obviously a lot of things to think about. I have two questions, just curious to pick your brain about. So one, a little bit building on what Michael asked. is like, first, I feel like I'm curious from your international perspective, like as clinicians in academia in the US with all this happening, like how do you think we should be advocating? In some ways, it feels a little bit like I felt a bit helpless in the past couple of weeks, just seeing all these changes. So curious from your perspective, like how should we in the US be like advocating on a national scale or international scale? And then second is I know that your career has spanned like academia, private sector, now that head of a BMJ. Curious your thoughts on where in the bigger picture of global surgery, where is academia's strength lies and like how to leverage kind of being in academia for the broader
Yeah.
global surgery movement. If it's a broad question, but curious your thoughts.
Two really difficult questions. You guys are throwing me the straight shots, huh? That feeling of powerlessness is not just you. I think all of us have struggled with that feeling of powerlessness. We are individuals or we're small collectives of people facing a behemoth and a movement that's been built over the last 30, 40 years that's now sort of coming to its own. It feels like a tough place to be, and that's because it is. I think one thing I would encourage you all is that these movements don't last. I don't know what it's going to look like over the next 3 or 4 or 5 years. These movements don't last. They do end up either self-cannibalizing or just kind of what's the word? Mitigating. There's a word I can't come to my mind right now. Haven't had coffee yet. But they don't end up lasting. I think our role here is the other problem that we face in the US is that speaking negatively can have impacts on our own individual careers. And as trainees, you're just at the start of your career. So that is a balance that each person has to make for themselves of how they want to speak. But these movements fall locally. These movements, it's none of us is sitting in Washington, D.C. right now, but you are sitting in San Francisco right now. I am sitting in New York City right now. There's stuff that I can do in New York City. There's stuff that you can do in San Francisco to both counteract this movement, but also to support the people who are specifically impacted by it. Where do academia, private sector, et cetera, sit in this? I'm not sure I'm going to answer your question well, so tell me if I didn't, Mary, but again, I think all of them have a role. Academia's role is the creation of and propagation of fact, for lack of a better word, of truth. But as I said to Michael, that's slow. That takes time. Evidence is slow moving. I do think it's really important for us who are in academia to remain academic. And in the global surgery space, we have wanted very much to advocate for good reason because 70% of the world doesn't have access to surgery. There's a lot of advocacy that needs to be done there. Really important for us to maintain scientific rigor when we do that so that people can cite our papers and be like, no, this is actually a really strong paper. And also, oh my gosh, 70% of the world can't access surgery. I think we need to keep that a little bit, that demarcation a little bit cleaner so that when we are advocating based on research that is a little bit more dispassionate. Again, I don't know if I fully answered your question, but those are my thoughts.
Thanks so much.
It is 7:30, so I want to allow those that have to sign up for Tumor Board to go ahead and go. We'll stand for a couple more minutes. Dr. Shrime, if you have a couple more minutes, I'm sure there might be a couple other questions that might filter through. Let's see if nobody else has another question. I have one other quick question for you, and that's your role as CMO of Mercy Ships. You kind of hinted at it, but I'd love to hear about the sort of prep work that goes into preparing to go into a country and to be there for an extended period of time, like what that even looks like and that sort of strategy designing and how you guys communicate with local governments and things like that. Yeah, I'd love to learn more about that.
That's a great question. A lot of MERS ships visible work is when the ships are there. Again, these big white hospital ships are they're hard to miss. We start engaging with countries 2 to 3 years before the ship actually gets there, and there's an entire sort of broadly 5-year engagement plan, of which the ship's arrival is the midpoint of it. So we only come into countries under invitation, and that invitation is not just a sort of handshake. It takes its form as a legal binding protocol between the country and the NGO, what the NGO is going to provide, what the country is going to provide and support, and how all of it's going to work. What does malpractice insurance look like? Like, everything is in a legal document that invites us into the country. Then prior to the ship being there, we start building, like any other NGO, we have to build an office in the country. We start those conversations about Austin Demby would like us to focus on nurse anesthesia in Sierra Leone. Those conversations started well before the ship got there. So we can start building that infrastructure that's necessary to launch an educational program even before the ship gets there. So it really is done. We have, every country has its own, we call them country directors. Every country has its own diplomatic liaison with the Ministry of Health, the Ministry of Foreign Affairs, the Ministry of Education. So again, we send them reports on a monthly basis. It is really, we try really hard to be as much of a partner as we can.
That's awesome. Thank you. And my last question for you, in case anybody else has any, is we have many trainees I know personally in our program who have been interested in global health and who have had different touch points with global health. A lot of it has been through academia, as Mary, Dr. Ju had mentioned. And I remember when I was a med student, I came and met you at Mass Center, and you kind of talked to me about the different buckets of how we can make an impact in global health. And I'm curious, outside of the traditional academic model of kind of working to produce research, what are the other ways that you see ENTs or trainees going on to be involved and be successful in a meaningful way that's more than just the kind of stereotypical mission trips that I think is often most successful, but sometimes people are a little bit more hesitant to get involved with?
Yeah, and fair. There should be hesitation, and there's a whole other talk about that. I think the buckets that you're talking about, if I remember this conversation correctly, we followed basically how a bill becomes law. Like, how does a policy get enacted? And it starts as research. The research then gets translated into a policy document, a policy brief. That policy brief then ends up on the advisor's desk. So not the Minister of Health quite yet. It ends up on the advisor's desk, whether it's a deputy or a permanent secretary or whatever. And then that person is the one that basically whispers in the ear of the minister and says, "Hey, minister, this is what we should do." That is a very convoluted path. And there are places to impact on every single step of that path. What I will say is that no one person can do all of that. So one of the things that I would say to people early in their careers is, which of these 4 areas strikes the biggest chord with you? Do you want to be generating the science? Do you want to be writing the policy brief? Do you want to be the advisor? Do you want to be the Minister of Health? Or sort of everything in that path in between? 2 other things I will say. I said it already. As a resident, your primary goal is to be the best dang resident that you can be. And I say this at every talk, to every level of trainee, because however you want to impact it, whether you want to be at the coal face doing the surgeries or otherwise, you're going to face things that you never faced in your residency training, and you want to be as well prepared for that as you can be. And then the last thing is, I'm really glad you asked this, because when I was training, at least, there weren't a lot of examples of people who are on non-traditional career paths in medicine. You went from high school to college, you were pre-med, then you went to med school, and basically you're on this track up until retirement. There are a whole bunch of different ways to improve the health of patients. For most doctors, it'll be at the bedside, but it doesn't have to be. And there's a whole vast world out there of career paths to explore.
Thank you, Dr. Shrime. Do we have Alex, one of our residents, has a quick question for you as well. Thank you so much.
Yeah, go for it. I've got like 2 more minutes.
Okay, thanks, Dr. Shrime. Provoking talk. I'm one of the PGY3s. Just always you know, I'm sure it's different for everybody, but kind of interested in hearing your journey to weighing different factors as I imagine, you know, going through training and then afterwards that you constantly have to battle. And as a resident, I feel like in addition to figuring out the medicine and the surgery, we're like trying to negotiate in our head like what we imagine a future practice could look like. But when sort of in your timeline was it like was the seed planted to like make this a big part to make sort of mercy ships or kind of a global surgery component a big part of your journey? And did it shape up exactly how you thought, or you know how that also intertwined with your head and neck component, you know, just how the confluence of all those factors might have integrated?
Yeah, no, that's a great question. I honestly wish I had more than 2 minutes to give it justice. The easiest question to answer on all of those was, did it turn out the way I thought? Absolutely not. Had you told me that I would be the CMO of an organization and then I would move on to be the editor in chief of like, no, I would never have thought that when I was sitting as a PGY3 resident at all. That kind of does get to the answer I just gave, which is, yeah, like as a PGY3, learn to do the surgeries, like really be really good at the surgeries and the clinical care. But as you're doing that, you are developing a whole bunch of other skills almost by accident or almost, you know, by habit. You're developing customer care skills. You are developing analytics skills. You're developing ways of thinking. You're developing mental frameworks. All these things can serve you really well, whether you decide to stay at the bedside or move on to something else. Um, uh, it feels often when we're in training that the only marketable skills we have are the cutting and the sewing, but that's not true. And that actually can get you to feel a little bit trapped of like, maybe I do want to explore research, but I'm a surgeon. I just, and I know training has changed since, you know, the 1800s when I was doing it. But I would encourage that really briefly before I have to run. I first encountered mercy ships when I'd finished my first fellowship and then went back to do a second fellowship in microvascular. And between those, I took a gap year essentially. And that was the first time I encountered mercy ships. And that was when I was like, oh crap, this is what I want to do. And that was 2008. I did not close my practice in the US until 2018. So it was 10 years of slowly moving in this direction. And I will end with that.
Thank you.
Thank you so much, Dr. Shrime. I really appreciate you making the time. Really, that was an impactful talk. So thank you so much. Really appreciate
Thanks,
it.
everyone. Thanks for having me.